So I'm here with Dr. Ryan Jorgenson, who was a fellow here at University of Nebraska Medical Center and graduated in last June in 2023. And I thought it would be good to have a conversation with him about fellowship and the benefits of that, or why he did it, because he's out in the community and is an ultrasound director at a community hospital. So, Ryan, do you mind just telling us about your hospital, where you're at?
Yes, I'm up in Sioux Falls, South Dakota now at a hospital organization called Avera, and we have a main campus here as well as a couple freestanding ERs that we cover, and then some of us work at a heart hospital as well. So it's a community center, but there are medical students that rotate through. There are family med residents, internal medicine residents that also rotate with us in the ER, but no emergency medicine residents.
And so, I got to work with you when you're a resident, and you're part of our residency program, and I feel that we have a pretty extensive ultrasound curriculum, and so I think you got a decent exposure then. But you even came to me early in second year of your residency and said, hey, I'm wanting to do fellowship was fellowship something you were interested from, like, before you came to residency? Is that something that developed over time, or kind of what led to that?
I had no intention of doing a fellowship when I started residency. My plan was 3 years back to South Dakota. I thought I'd spent enough time learning at that point and wanted to just get to work. But early on, I had a couple very memorable patient encounters where the use of ultrasound really had a significant impact on the patient's outcome and the management plan we had for that patient. And so that piqued my interest early on. And then, like you said, I started talking with you more about the possibility of pursuing a fellowship and what that would mean for me, with the high likelihood that I was going to end up back in a community setting. And so as I explored what you can do with point of care ultrasound, as well as the educational component of it that you can have in your career, it just became a better and better fit for me.
And maybe if you don't mind telling us, so you actually negotiated a contract before you, or while you were applying to fellowship, and they wanted you to start earlier, and kind of had discussions with them. And do you mind just kind of telling us what happened there and how that worked out?
Yeah, so the group I joined, several of them will use ultrasound at the bedside, but there's no infrastructure for it to be ordered as a point of care study to save the images, to generate a report. And for me, I really knew that that's something I needed in my career. I knew I was going to use point of care ultrasound no matter where I was at. And with my desire to really join this group, ever since I was in medical school, there was kind of two ways I was thinking about it. One is I joined the group and I try to stumble my way through how do we get this set up, or what I thought was a much more reasonable route is I wanted to pursue the fellowship and learn the administrative aspects of what it takes to run an ultrasound program. And the administrators here, the docs here are really supportive, really open to what's best for the patient. And ultimately it came down to, we think this is going to provide the best care we can for these patients. And so they were open to looking into this component of emergency medicine that they weren't really pursuing at the time, and work with me to make it happen.
And they actually held that spot for over a year for you. Is that right?
Yeah, they were hoping to hire somebody what would have been in January of my fellowship year. So they kind of held that spot for another 6-7 months until I could start there.
And this might be jumping ahead. We'll come back and talk about, fellowship a little bit more, but what has been your experience coming out of fellowship and working with them on developing your program?
It's been very, very good. I was a little bit nervous because it's a big jump to go from the learner to the expert in a certain part of emergency medicine. But the organization, from my colleagues, the other physicians in the group, to the administrators, to the IT people, and we've had a lot of meetings. They're fully supportive of kind of doing what it takes to set this up the right way. And so even before I had started the position, they were already having some meetings to, say, okay, what's this going to look like? How are we going to do some of the background work from the IT side of it, from the EMR side, to get this up and running?
Had you not had fellowship, how would that have gone? You said you had mentioned. So poorly, why? I mean, like, what was the difference?
Yeah, I think that, like you mentioned, our curriculum at UNMC was very extensive. I felt very comfortable with sort of the basic ultrasound applications for point of care emergency medicine use. That wasn't why I did fellowship. I know some people may do it because they want more training in that, but for me, it was an interest in the advanced side of POCUS, but also so much that goes into the behind the scenes work of getting a program running, from the QA, understanding the billing, the CPT codes, kind of knowing the right wording to use when you're meeting with the head of the radiology department in week 1 to discuss starting point of care ultrasound, which absolutely went well. He's a fantastic guy and was very supportive. So it's just, there's so much behind the scenes stuff you don't know when you're in residency, and fellowship really was enlightening in regard to that.
Yeah, I have a lot of residents reach out to me. Well, I should say graduates reach out to me after and say, "Hey, I come in and I know the most about ultrasound, so they ask me to, run the program." What advice would you give them if they get tagged to do that?
I would be, if it was me in that situation and I hadn't done a fellowship, I'd be very enthusiastic about that, because that's a great opportunity, but I would be very hesitant to blindly say yes, because I think that there would be a significant amount of work that you're agreeing to that you might not realize. And keep in mind that the amount of work you're going to do, even with all the knowledge from a fellowship, you're going to multiply that 2-3-fold, because you're going to be, stumbling is probably the wrong word to use, but for a lot of it, you don't have that background knowledge of the administrative side of it. And so you're going to have to learn that on the fly, and that's going to be a significant component of your time.
Yeah, and I'm going to mention here, I do help teach at that, so that's I guess a disclosure, but ASAP ultrasound management course is good for those individuals, but I still think fellowship is your best option to learn all of these management things, because I imagine when you walked into the room and you started meeting with all the administrators, you walk in and you have a knowledge base, right, that you would not have had otherwise.
Yeah, when we have the conversations, for the majority of the questions, you've already got the answer, and so I think that helps lend some credibility to what you're trying to do, especially if you're starting a POCUS program, because if you already have answers to the majority of the questions, you're going to have, like I said, some credibility to what you're doing. If the answer to everything is "I don't know," that doesn't mean you can't do this. It's going to be so much more of an uphill battle to get that done.
Well, that's great. That's a good impression, or a good thought on that. So coming back to fellowship, and I should have mentioned this earlier. So you've passed it's not a board, but it's your focus practice designation. You just passed that, so congratulations on doing that. That's a big accomplishment. And so that's the benefit of fellowship. You also can sit for that if you're emergency medicine trained and ABEM certified. But what was the biggest surprise in fellowship to you?
The work-life balance. After being in medical school and then residency and just grinding for so long, obviously you're still working hard in fellowship. And there were, we did plenty of shifts to sort of start developing your own independent practice style at the academic center as well as the community site. Very rigorous fellowship curriculum that I feel like I came out of it really well trained. And with all of that, I had some time to, spend time with family. So it's a really enjoyable year. You're going to learn so much. It's hopefully a field that you're really passionate about, so the learning is all the better. And there's time to have fun. So I very fondly look back on fellowship year.
My fellowship year, I remember thinking about, I learned a lot about ultrasound. Obviously have continued to learn a lot about ultrasound and try to instill that knowledge to others. But I feel like at times I learned as much in fellowship about doing emergency medicine as I did in almost my entire residency, because it's interesting, once you start having people ask you questions, you start seeing how other people think, and you start to think of things in other ways and really see that there are many ways to treat and accomplish the same goals and gain an understanding of some things. Do you have any thoughts on that? Or
I agree. I think it's in residency you get some of those shifts, at least in ours, where you're working with an intern or a medical student, as an upper level, and you get some of that experience, but it's really a different perspective when you're working an attending shift and working with residents, and you get, they ask you questions, and it makes you think about things in a different way because they might have had a different plan. And if you're working with a second or third year resident, their plan might be, just as good as what you had. So it broadens your understanding of ways to approach different patients. It was very helpful.
Yeah, I felt like I learned a lot then. So you did pass the AEMUS FPD. Do you see any benefits to that you moving forward, or how do you feel in community medicine? That one.
I think probably a lot of people that do fellowship are doing it with the goal of getting a specific job at an academic center. For me, obviously, that wasn't the case. But I think that focused practice designation just speaks to a level of training that is beneficial for the community. And for me, why I did fellowship was, one, my interest in ultrasound itself, but also with those patient outcomes that were affected by its use. I really felt like it was a way that I could best benefit my community by having that skill set and helping to teach others. And so I think that the focused practice designation, it's not going to change, my contract or my career path here at this community hospital, but I think it just, again, lends some credibility to what we're trying to do here in starting up this ultrasound program.
Yeah, I think that is a good thought. I mean, we went years for it. I was not, our fellowship became accredited. I trained years before that, and I think it's great for the graduates that they have that because it can continue to speak to what they're accomplishing. So tell me, maybe just backing up, talking clinically, tell me about one or two cases that you've had since you've been there that's just really had, maybe has demonstrated to the administration there, like, this is great, we should have been doing this years ago, or maybe one of your colleagues has had that you've been there and it's improved. You've improved the department that way.
Yeah, the first one I did. So we got this up and running in October, and the very first case I had, the patient came in with concerning vital signs, and with the use of POCUS as she arrived with EMS, she had a very dilated RV. Her left ventricle was hyperdynamic, and right away we were very, very concerned with her history about a PE, and that really tipped us over the edge. And so the heparin was ordered before we had the CT scan done, and really as she came out of the CT scanner, our pharmacist showed up with the heparin, and we started it in the CT scanner room, and she ended up going for thrombectomy. And so right off the bat, that was a great case of, did it change getting the diagnosis? No, because PE was on our differential. That was suspected for this patient, but it expedited her care significantly to the point that as she was coming off the scanner, we started the heparin. And I had another similar case not too long ago with a patient that it very much sounded like just an orthostatic syncopal episode. But she had some risk factors, so I put the ultrasound probe on her chest, and I could actually see a clot in her atria. And so that very significantly changed our workup for her. And again, she got started on heparin immediately. And then the CT confirmed the PEs that, again, we probably would have eventually got there with her history. She probably would have ended up with a CT, but it helped us arrive at the diagnosis as the patient arrived to the emergency department, as opposed to maybe an hour later, or if it's a busy day and the CT's backed up, a couple hours later.
Let me ask you this, just because you bring up two good cases, I mean, those are critical patients. From the time you walk into the room to the time you essentially had verification of your suspicions, how long did that take?
For the first case, about 6 minutes probably. And then the second case, that one I think was about 15 or 20 minutes, because I stepped back out after talking with her and just kind of having a little bit of that something seems a little bit off here type of feeling.
That's great. I mean, I think that's the thing. The whole idea of POCUS is early intervention, right? Doing it early and finding it. I mean, those are great cases for that.
And I would say those are obviously very significant cases, but also just from a bread and butter standpoint, a lot of procedural use here for fracture reductions, which coming out of residency, we've got an ortho residency at UNMC, so they do the majority of the reductions. And using the ultrasound to guide the fracture reductions for me has been a really big confidence booster to just quick look and say, yep, it is reduced adequately. I'll splint it. and have peace of mind that I'm not going to be going back to that room and taking a splint down and spending more time on it.
That's great. That's awesome. Tell me where you're at. So you said you initially met with the administrators, and now, we're almost a year in, not quite, maybe 9 months in. Where are you guys at now as far as ultrasound goes? Or maybe did they have any infrastructure to start with?
Yeah, so to start, no. There was no orderable procedure. There was nothing in our EMR.
They had an ultrasound machine though, right?
They had one new machine at one of the sites, and then we have 2 other machines that would benefit from being updated soon, hopefully. About 3 months into the job, the team was amazing. They had it up and running to the point that I could order just a generic point of care ultrasound, and that was enough. I could fill out my own reports that I had templates for using what our radiologists use here, PowerScribe. And then fast forward to today, we just launched study-specific orders at this point, so you can order a point of care cardiac versus a point of care thoracic, et cetera. And hopefully with that being in place, it's going to be at the point where if I have other group members that are interested, we'll hopefully start opening the use of it up to them now that we sort of have the trial run done and we've got it up and running.
And you guys were not billing before, correct?
No.
Are you at this point, or are you still building to that?
Yeah, we've been billing since October.
And that's all due to you, right? Well,
that's due to a lot of people.
Yeah. But I mean, you coming in and saying, here's what we need to do, and getting there, right?
Yeah, I think that played a good role. It was a bit of a catalyst for it, but yeah, there's a very large team that's making that happen.
Yeah, and I don't want to ignore that. That's not what I meant. What I meant is they've had, and what I imply is that they had an ultrasound at their facilities for quite a while, and yet they were not billing for those things. They didn't have the infrastructure to do that. It sounds like you put them on that right path to have that infrastructure, and that's what community places need, in my opinion.
Yeah.
So, what's has this opened any doors for you, and what's the future hold?
For me, I think my goal is hopefully, I know there are some colleagues in my group that are interested in incorporating more point of care ultrasound use, and so hopefully, first and foremost, helping anybody that's interested in learning more about it, whether it's just I want to use it for procedures, or if anybody's interested in more advanced ultrasound, it'd be a really good opportunity to do some teaching there. I've done a little bit of teaching at the medical school with some ultrasound lectures, and I'm hoping to get more involved in that, but I'm kind of guarding my time a little bit. I want to focus on getting it going in our department first. And there's a couple of residencies here, and that would be a great opportunity as well. I really enjoy doing ultrasound education, so I think that's part of my goal for the future.
That's great. What would you say to somebody then, through all this experience where you're at now, if somebody was on the fence of whether to do an ultrasound fellowship, or maybe even any fellowship for their future career, what advice would you give them going into community medicine?
I think that for me, first and foremost, it was just a patient-oriented decision. I just really felt like it benefited several of my patients, and so does everybody have to do a fellowship to practice community medicine? Of course not. But I had a passion for ultrasound, and I wanted to bring that passion and that benefit to my community. And I think that if you are interested in it, I don't think you're going to regret learning more about this field and becoming an expert in it, and having, being the point person that your colleagues may look to for some advice. It's a really unique perspective to be one of the newest members of my group and be very aware of that, but also in one part of emergency medicine, really be the expert for my group and be able to bring that to everybody. So.
That's great, man. I appreciate you taking the time to discuss this. I think this is I think so many people only look at fellowship as, if I do fellowship, I'm going to academics, and I think there's a lot that's needed in community medicine, and I think POCUS is definitely an area where people can do fellowship and be leaders in their community environments, and I think you're a great example of that. So thanks for taking the time to talk with me today about it.
Yeah, of course. It's a pleasure.